So good afternoon and good morning to everyone. Thank you for joining us for the first session of the 2021 Older Adults and Opioid webinar series hosted by the Finger Lakes Geriatric Education Center, a HRSA-funded Geriatric Workforce Enhancement Program, or GWEP, at the University of Rochester, also sponsored by the Western New York Rural Area Health Education Center and the Monroe County Department of Public Health. My name is Laura Robinson, and I am the program coordinator for the Finger Lakes Geriatric Education Center. We are very glad you could join us today. Just a couple housekeeping items before we begin. There are two important buttons on your Zoom toolbar. Please use the chat button right now to type hello and introduce yourself with a name, job title, agency, and location. We have people from across the country joining us today, and we do have a couple international registrants as well. The Q&A button will allow you to type in a question for the presenter. We ask that you use this button at any time during the presentation to ask a question so that the question does not get lost in the chat, and we will address all the questions at the end of the session. So now I'll introduce a little bit about our sponsors. So the Finger Lakes Geriatric Education Center has been continuously funded by HRSA since 1999. We currently serve a 25-county area of the Finger Lakes region, but truly serve all of New York State through collaborations with many academic and community-based partners. Through educational initiatives targeting all healthcare providers and family caregivers, the goal of the FLGEC is to transform clinical training environments by integrating geriatrics into primary care delivery systems, resulting in an age-friendly health system, as well as dementia-friendly communities. The Monroe County Department of Public Health has a long history of collaboration with the University of Rochester and the Finger Lakes Geriatric Education Center. The Monroe County Department of Public Health provides direct public health services designed to protect the public from disease and environmental hazards and community leadership to ensure improved health status of individuals, families, and the environment. Their services include education, preventive services, and enforcement of health codes and medical policies. And the Western New York Rural Area Health Education Center, or R-AHEC for short, is a nonprofit organization headquartered in Warsaw, New York, serving 12 counties. The R-AHEC's mission is to improve health and healthcare through education. R-AHEC addresses the health needs of its communities by focusing on health workforce development, preceptor development and student housing, pipeline programming, and rural healthcare technology infrastructure development. So now I'm going to go to our disclosure slides. We are approved for CME and social work credit for this presentation. So with that, we had a planning committee put this together. All of our planning committee members have disclosed that they have no relevant financial or other interests in this program, so no disclosures to make. But our speaker today has disclosed one thing. She's a minor stockholder in a few different companies that should not bias the presentation. Details on how to access your continuing education credits will be emailed to you after this presentation and after attendance is sent over to our continuing education office. So please be sure to introduce yourself in the chat, especially if your Zoom name is different than your real name. And if you can change your name, that's more than welcome as well. So now I'm going to stop sharing my screen and allow Dr. Smith to share her screen and bring up her slides while I introduce her. Our featured speaker today is Dr. Tisha Smith. She is the Addiction Services Director for Monroe County Department of Public Health. Dr. Smith holds a doctorate degree in education, executive leadership from St. John Fisher College, and both a master's degree in public policy and a bachelor's degree in criminal justice from the Rochester Institute of Technology. She has focused her research on the prison re-entry experiences of African American men, homicide and the political response to criminal victimization, police and community relations, and forensic entomology. She was recently the Director of Inmate Drug and Alcohol Programs for the Monroe County Sheriff's Office. She was responsible for the development of programs for the Drug and Alcohol Program, Veterans Unit, and the Medication-Assisted Treatment Units at the Monroe County Jail. Just prior to that appointment, she was the supervisor of the Inpatient Chemical Dependency Unit at Rochester Regional's Unity Hospital. She was just recently appointed to the Addiction Services Director for Monroe County Department of Public Health, and this was in 2020. So now I will turn the program over to Dr. Smith.
Hi, thank you so much. I'm honored to be here today. I wanted to talk today about what's really in our medicine cabinet and how the prescription of opioids is affecting our community, in particular our older folks. So what's really in our medicine cabinet? So this is my contact information. Please feel to reach out to me at any time. Um, and so today's objectives, I wanted to kind of help everyone get a better understanding of how easy it is to potentially overdose and pass away from continued use of opiates. And I also wanted to give people a little bit of an understanding of some of the unintended consequences of continuing to prescribe opiates to the elderly, and also learn some of the additional resources in our community that will help with opioid use disorder. By way of just kind of doing a little bit of housekeeping, I know that folks that are in the business of providing services for people in the community, we kind of interchange our use of the words opiates and opioids. And so the differences are that opiates are the natural kinds of drugs that you might find, like opium is found in poppies, right? But we also have synthetic opioids like heroin that we kind of, like I said, just kind of interchange those two terms. So you might hear me use opiates and opioids today, but you'll kind of get my gist. And so I kind of wanted to start this off by talking about some of the existing research with regard to the elderly and the prescription of opioid drugs. So I found this clip, and though it doesn't deal exactly with our topic, you'll see why I included it as we go on a little further. So without further ado, we're going to start this video. Maybe not.
Hi, I'm Dr. Preeti Malani, Director of the National Poll on Healthy Aging. Our poll on prescription drugs has brought up some important and timely issues. It seems that many older adults aren't getting or seeking help from doctors and pharmacists on drug costs that a lot of seniors find difficult to pay, especially those who take several medications and see multiple doctors. In many cases, patients assume that their doctors know how much their medications cost, but that's not always the case. As clinicians, we should also be more proactive in starting conversations with patients about drug costs, and when it's possible, we can think about prescribing lower-cost alternatives. The results of the study suggest that patients should also ask about ways to reduce their prescription costs, both during their doctor's visits and at the pharmacy. Here are some more of the findings.
The majority of Americans over age 50 take 2 or more prescription drugs to prevent or treat health problems. 27% of all poll respondents said their prescription drug costs pose a financial burden. That percentage was higher among those taking more medications and seeing more doctors. Among those who reported a prescription drug cost burden, half said they had not talked with their doctor about the price of their drugs. Among those who talked with their doctor about prescription drug costs, 2/3 said their doctor recommended lower cost alternatives, while 37% said their pharmacist had done the same. Based on these findings, here's a patient tip that might help. If your prescription drugs are too expensive, mention it to your doctor at your next appointment, or talk with a pharmacist about possible alternatives. For the latest research and to learn more about the National Poll on Healthy Aging, visit healthyagingpoll.org.
So when I first saw that clip, I thought of how we stereotypically think of elderly patients leaving traditional forms of medication and then going to the illicit substances based upon the fact that they can no longer afford their medications. That's one of the potential reasons for the increase in the amount of elderly patients going out and using heroin and subsequently overdosing and passing away. And so I started to think about this topic a little deeper when I was asked to talk about this. And And one of the things that kind of struck me was that when we're talking about this population, we stereotypically think of elderly people as elderly, right? And we don't really assume that they could be potential risks for opiate use, right? Or illicit substances, I'm going to say, because they don't really fit that profile of what we think addicts should look like or behave. And I, in the course of, digging deeper into this particular research project, that was one of the things that kind of struck me, is that there's this assumption, I think, among society that, grandma is not shooting heroin, but indeed, grandma could be out there shooting heroin. And then there was another kind of myth that was, born out of this research, where they started to talk about how doctors just kind of willy-nilly, started prescribing all these opioids, and it flooded the market, or flooded the community, if you will, with opiates, and without the kind of forethought that this could potentially be a problem. And I don't really think that is the case. I think, my own experience going to the doctor, if I'm prescribed something that's, way less powerful than an opioid, there's a discussion about things. So I'm not quite sure that that's the finding that they wanted to kind of leave people with, but that was something that I got as I did a deeper dive into this research project. But I found that it was very interesting, because I truly believe that people understand that opioids do affect our brain chemistry, and therefore inform our behavior, and therefore inform our ability to process things and rationalize. And I think the medical profession has at least that understanding. And I don't really think that is the issue with regard to our elderly folks. So this study was done using responses from people aged 50 to age 80. I don't know how comfortable I am with them putting the 50-year-olds in that category, but nevertheless, 50-year-olds were included in this study. And so one of the things that is quite striking to me was that not only are we getting prescribed medicines, right, medications, but at the last column, the 37% didn't have a discussion with their physicians about what to do with leftover medication. And in addition to that, over half of them were not spoken to with regard to how to reduce that amount. And almost half of them didn't discuss the risk of overdose, which was, I thought, kind of striking, which begs the question, what exactly are we doing when we're prescribing these medications? Another interesting finding from this was about your medicine cabinet. 86% of people suggested that they kept these medications like for a rainy day. So that's 86% of these people have these medications just floating around in their medicine cabinet, which kind of leads me to wonder if, like my experience in inpatient chemical dependency, I'll give you an example. When I started in the mid 2000s, I was dealing with a lot of patients that were coming in with alcohol issues, right? And so for about a year or two, all of the patients that were coming in were basically older, middle-aged adults with issues with alcohol. And then out of nowhere, we were hit with a slew of younger people coming in for inpatient chemical dependency treatment. And these young people were like young, like fresh out of high school young, like just graduated like the year before kind of young. And they were all addicted to heroin, primarily from the west side of the city of Rochester. And it was just one after the other, after the other, after the other. And I'm like, what the heck is going on? And so in talking to folks, like there were a lot of my patients that came in that were not addicted to any other medication or any other drug other than heroin. There was no marijuana use, there was no cigarette use, there was no alcohol use, and it was just straight heroin. And I was like, of course I'm nosy, so I'm asking why straight to heroin. And so they all talked about having access to pain medications from older members of their family, and they liked the effects of it. They were buying it. It became too expensive, and then they moved on to heroin, and this became like a trend. And then over time, the people that were coming in addicted to heroin were getting older and older and older and older. So I think, this finding of having people people keeping their medications in their medicine cabinet for like a rainy day says something. In addition to this poll, I started to think of like all of the unintended consequences. And so they talked about how there were quite a few people in this poll who had received a prescription for opioids within the last 2 years, and half of them had leftover stuff in their medication, right? And then in addition to that, they started to talk about how medicine cabinets were the most common source for people to get access to medications. And so this unintended consequence of the prescribing of these drugs is that they can fall into the wrong hands, or that patients could actually self-medicate. And so when I started to think about self-medication, I started to think about how innocuous it is for all of us to actually overdose on medication. And I'll give you another example of how easy it is. I was working in the hospital, and there was a patient that was talking to one of the nurses in the med station, and she had asked for some ibuprofen. And the nurse had I'm just walking by as this is going down. So the nurse had said, I can't give you this because you just had whatever medication it was, and it's too soon for me to give you this medication. And as I was walking by hearing this, I started to think about how easy it is for us regular citizens to kind of play doctor. So like, I'll give you an example. Like, let's say hypothetically you had a cold. You take some medication for your cold, and then a couple hours later, you're still not feeling just right. And so you'll go back to the medicine cabinet, you'll grab something, and then you'll think, oh, I got something else. And then you kind of like make your own little concoction to kind of ease your symptoms related to this cold. And it's so easy for us to actually overdose that we don't even like think about it. And so when we're talking about the elderly who already stated in this poll that they weren't even spoken to about the potential risk for overdose, now you've got it in their medicine cabinet, they got another like ache or pain, and then they can easily take this medication because it's at their disposal, and they could potentially overdose and pass away. So another unintended consequence of prescribing opiates to our elderly. In addition to this, there has been a lot of discussion about the prescription of medication for pain. There are a lot of people in our country and the world who are prescribed opiates for pain. And as a result of the intense scrutiny on the prescription of these medications because of the the opiate crisis that we've had in our country and around the world, the way doctors prescribe has changed. And there are different rules and regulations that are put in place now to kind of monitor that. And because of that, there are a community of people that are taking medications specifically for pain that are struggling with these new rules and regulations. And so they're unable to get the medications that they need in the doses that they were accustomed to getting them before, or in the amount that they were getting them before. And so this study suggested that we have another unintended consequence of prescribing opiates. A couple of weeks ago, I was informed that due to COVID, we now have a needle shortage in this country, something that's not really talked about. And then when I heard it, I remember thinking, like, my first thought was, what are people going to do if there's a needle shortage? If you're intravenously injecting heroin, what will you do? You will probably reuse the needles that you do have. And in reusing those needles, those of us in the profession know that reusing needles can potentially lead people down a dangerous path of infection, at risk for HIV, hepatitis, STDs, right? And again, another unintended consequence of continued IV drug use that we don't really even think of. A few years ago, I had the privilege of going to our local needle exchange program, and they had a poster, or no, it was a brochure with this picture on it. And it was the first time I had seen it. And so I thought I would share it today in case, some folks hadn't seen it. And so when we're looking at reused needles, the first shot is the needle the first time they use it. And then as it goes on, you can see if a reused needle 6 times looks like that, if it's contaminated, think of all of the risks that people are put at if they use those needles. So I just thought I would share that with you. So New York State has developed an opioid dashboard. So if you do a Google search for opioid dashboard, you'll actually see this a whole entire array of statistics that have been compiled to talk about the state of our state with regard to opioids. And if you kind of look a little close to your screen, you'll see that 17.2 overdose deaths involving any drug for our population, 45 to 64 years old, has significantly worsened in New York State. And then on the next slide, if you look at, where are we? 21.2. 21.2 has the overall overdose deaths related to heroin, and then there's no significant change. However, I'll talk specifically about what's going on in Monroe County shortly. And then the next one, we're looking at 23.2, opioid deaths involving opioid pain relievers, including illicitly produced drugs. So that includes fentanyl. So that is for age 45 to 64. You'll see that it has significantly worsened in New York State. So let's look at the link between painkillers and heroin. I love these kinds of slides because they're kind of easy to kind of like quote. And some of the statistics are kind of like graphic. So these are stereotypically used to really gain people's attention. And as you can see, those folks that are using opioid painkillers are at 40 times greater risk and more likely to be addicted to heroin. Now, why is that? We can talk about cost, we can talk about availability, we can talk about the effects on the individual. It's something that I think medical professionals are highly aware of nowadays, but maybe not so much in the past. I remember having a discussion with my own doctor because he knows what I do. And so we had these intellectual discussions during our doctor's appointment, or my doctor's appointment. And we had this discussion and he talked about painkillers and how he said that, we were sold a bill of goods, and like in medical school, like you would, meet all these pharmaceutical reps and they would tell you how wonderful these medications are and that it would definitely ease the pain of your patients. And so people were just prescribing them, not really considering the fact that down the line there could be a problem. And it reminds me of a few years ago. So it's probably like 2006, 2007. I was attending a conference specifically about crime and public safety. And then it morphed into a drug and alcohol conference. And I was there with my supervisor. We're sitting at a table and, just shooting the breeze, just chit chatting. And we had probably about 10 seats around this big, gigantic table in this hotel and around us that were empty. And so a group of women came by and they said, hey, can we sit here? And we're like, yeah, sure. So we started, talking to these women, and it was a whole group of women from West Virginia. And I remember sitting there thinking, like, y'all got crime in West Virginia? Like, what's going on in West Virginia? I think after everything she said to me, I kept saying, in West Virginia? Just never imagined it. And so she said to me, this is in 2006, 2007, that they had a problem with opiates and that people were dying from overdose. And I kept saying, in West Virginia? And she said, yeah, in West Virginia. And then she said, coal miners. And I was like, oh, wow. So coal miners were being prescribed these opiates as a result of their pain taking more than they were prescribed and dying. And this is in 2006. And so it took the rest of the country, years to catch up with that, but people were dying. And so I was just kind of, it kind of just stuck in the back of my mind. And then all these years later, here in our fair city, we now have an issue. Shortly before I started here, which was about 3 months ago, our medical examiner had issued a report. I think it was either shortly after I started or shortly before I started. All I know is I heard about it just when I got here, and I remember reading it. And there were some very interesting findings. And so to date, in Monroe County, we've had 181 deaths that were related to heroin, fentanyl, or any of the other drugs that are derived from those drugs. And that is a lot. But what it does also say is that it was down from previous years. So that was good news for people working on this issue. However, it also said a few more things. I remember when I just heard that alone, and I also heard some other statistics that made me think, like when I got here in this position, which was a newly created position, to work on the opioid issue in our community, I was like, yeah, this is what we're going to do. And then I learned some more things, and I'm going to show you what I learned. What I learned after reading the medical examiner's report was that there's an overwhelming percentage of our folks that pass away as a result of overdose that are Caucasian, but the numbers for African Americans and Hispanics in our community somehow have increased. And as soon as I heard that, I was like, yeah, we're going to go into these, underserved communities, and we're going to get people connected to services and talk to people about treatment, get people Narcan trained. We're going to do all this stuff to help our community, and we're going to target this African American, Hispanic community, and just spread the gospel of sobriety. And then I learned some other things, and then that kind of changed everything. So, but if you go down a little further and you look at this chart, kind of toward the right-hand side, that's how the ages increase. And so from the middle of the chart over, you can see that we actually have had people over 70 years old in our community pass away as a result of overdose. So it affects not just our younger drug users, but also our adult population as well. This is why everything changed. So Monroe County Heroin Task Force. My former employer, the Monroe County Sheriff's Office, has convened a task force of people, which is different than the opioid task force. There's an opioid task force in Rochester, and then there is a heroin task force. A heroin task force is specifically Sheriff's Office, DA, a couple of other local police departments, and they all focus specifically on this topic. So this is what changed everything for me. So if you see in the center of the picture is the city of Rochester. The blue dots are our overdoses, and our red dots are our fatal overdoses. But as you can see, those dots are spread all over the county. So it's not just an inner city problem. It's not just a city of Rochester problem. We have had deaths and overdoses in multiple communities across Monroe County. And so that kind of changed my idea of where we were going to target our interventions. It needs to be a community-wide effort and not just specifically the city, in particular, the Clinton Avenue area. This is going to be a community-wide effort. And then when you really, really think about things, these are only the overdoses that are reported to police or EMTs or EMS. Think about all the ones that happen at home or in the street or in drug houses or just anywhere within our community that goes unreported. Somebody gets Narcan by a neighbor or a friend or a fellow user, but they don't go to the hospital for that. They're just revived and they go on with their lives. So this is just a microcosm of the use that's in our community. And that's why I think we had to refocus our efforts to target the whole entire community and not just the known drug areas and the areas that are underserved. So that's what my new team is going to do. So when they did the autopsies of these folks and they looked at the drugs that were in people's system, 94.5% of the folks had fentanyl. That's not to say that everybody that had fentanyl in their system was seeking fentanyl or knew that they were taking fentanyl. It is believed that some of these fentanyl deaths are related to the term is cutting. Like, so you have you have your heroin and then they cut it with other things to improve the amount or the potency of what they have. And so it's believed that medications are cut with fentanyl in an effort to give the person a more extreme high so that they would be a repeat customer. So, but then there are also a contingent of people that are out there that are seeking fentanyl because they know that this high is going to be so extreme. And so with 94% of our folks having fentanyl in their system, there were some other interesting drugs on there that Flexeril, and which is a muscle relaxer, and also kratom, which is it's a leaf from a tree in South America. It's believed that it provides some kind of like psychotropic kind of effects on people. And so again, if it's cut with this stuff, it will then create this sense of euphoria that's unlike their stereotypical sense of euphoria as a result of using heroin. And so it gives people a different kind of high. And so if you get a different kind of high and you like that high, then you're going to tell everybody, and then everybody's going to go to that same dealer, and it increases the customer base for our dealers. So, and then the Flexeril was interesting to me. I was like, they're not cutting heroin with Flexeril. And then it was believed, when I started to talk to other people in the profession, it's believed that Flexeril was common in some of our folks that passed away because of restless leg syndrome being a byproduct of their continued drug use. And so they were using Flexeril anyway in an effort to relieve that symptom, but still using other drugs to get high. So we have a fentanyl problem in our community, as you can see, and it's not going away. And so that's something that we also have to work on as we do our outreach efforts and as we do chemical dependency treatment in our community. So I wanted to talk a little bit too about fentanyl. And, you know, when I talked about cutting the medication with fentanyl, it's believed really that a lot of folks are not seeking it. And I would say even like a majority of the people that passed away as a result of fentanyl and their heroin weren't exactly seeking fentanyl. It just happened to be that way. And so if you're thinking of our elderly population that's out in the community and they subsequently decide to use heroin, and it is tainted, cut, or even grazed fentanyl, the risk for overdose is extreme. And as you saw in the amount of deaths that we've seen in our community, there are elderly people in that population. And so it is a group that needs to hear this. It's a group that needs to be targeted when we're talking about outreach efforts because it's an ignored group within our community when it comes to kind of outreach efforts. So that's something that we're going to try and eradicate with our group going back out into the community. Excuse me. So let's watch this brief short on fentanyl.
Fentanyl is not a new drug, but has seen such a dramatic increase in the past 3 years that it has become a crisis in North America. Simply touching it may cause you to overdose, so what exactly does it do to your brain and body? Fentanyl is an opioid that can inhibit pain signals in multiple pathways along the brain and spinal cord. This is why it was initially prescribed for pain relief. It also causes your brain to make extra dopamine, creating sensations of intense euphoria and relaxation. Essentially, fentanyl hijacks your body's built-in system of endorphins by binding to your opioid receptors much in the same way your endorphins do, but at a significantly stronger level. This might sound fun, but activating these receptors can also suppress your brain's ability to detect CO2 levels in the body, potentially causing a person to stop breathing. On top of this, side effects include dizziness, chills, vomiting, fainting, difficulty urinating, and extreme constipation. In addition, fentanyl is much stronger than other opioids, 100 times stronger than morphine and 50 times stronger than heroin. For many drugs to work, they need to pass the blood-brain barrier. This barrier allows small fat-soluble substances to pass and water-loving molecules to be inhibited. Both morphine and heroin are lipid-soluble, but they have polar, water-loving groups that make them pass the barrier much more slowly, whereas fentanyl is extremely nonpolar and fat-soluble, entering the brain within seconds. This means you only need tiny amounts to get high, and that's where, in part, the danger lies. A lethal dose of fentanyl can be around 2 milligrams, in a test tube that looks like 2 grains of salt, and since a high level of precision is needed to dose it effectively, it's very easy to overdose. In fact, there are some reported incidents of first responders ODing from simply touching fentanyl powder or inhaling its dust, though some toxicologists doubt the accuracy of these cases. If it can be administered in time, an injection of naloxone can be given to a person, which works to stop an overdose by blocking opioid receptors. But the science cannot keep up with the rate of new fentanyl analogs being produced, like carfentanil, which is 10,000 times more powerful than morphine and has been cited for its possible use in chemical warfare. Today, drug overdose deaths in America are rising faster than ever, with 65,000 deaths in 2016 compared to 59,000 in 2015, and opioid use is the crux of the problem. For context, this is higher than the peak gun deaths, peak HIV deaths, and peak car crash deaths. All evidence points towards the problem worsening by the end of 2017. The reason? Research points to widespread prescription of opioids for pain, which leads to addiction. There's also an ease of access for non-prescribers, causing millions of tablets to fall into the wrong hands. As the danger became more clear, doctors decreased prescriptions of opiates, but this didn't change the fact that thousands of people were addicted, causing them to seek out illegal markets. With an increase in demand, illicit drug markets turned to cheaper production solutions. Unlike heroin, which is synthesized from poppies, fentanyl is entirely synthetic and can be made anywhere for cheap. China has become a heavyweight in manufacturing fentanyl, and North American law is working to seize supply. However, the UN urges that solutions to the crisis will lie in persuading people not to use opiates, as blocking China's market may simply cause production to move to another nation. Several experts are calling for government support for safe consumption sites where people suffering addiction can be supervised, minimizing risk of overdose, and be supported with counseling and anti-withdrawal drugs that can help people stop using. But can some drugs be good for you? Check out our second video here, where we look through the surprising benefits.
So, I really thought that graphic video, and the fact that it was so short, the graphics were pretty good, and just kind of, can get people to understand the seriousness of fentanyl. One of the other things that was mentioned in the short was that carfentanil is more potent than fentanyl. And so I think it was November of last year, we had received here at the Department of Public Health a warning from the New York State Department of Health that carfentanil was found in Utica. And so there was a warning that it could potentially come this way. So Dr. Mendoza, our Commissioner of Public Health, and I had issued a letter to community service providers to inform them of that it was found in the Utica area and that it could potentially come this way. So that is still something that should be on our radars as healthcare professionals moving forward. And so I wanted to talk about how to work through all of this and work with people that are dealing with substance use issues. And one of the things that I always tell my students is that it's not rocket science. I think people come into the profession thinking that they have to know what, alcohol synthesizes into after, it's metabolized in the liver. It's not that deep. When you're dealing with a human being, they need to know that you are there, that you care about them, and that you're going to do everything in your power to help them get from point A to point B and lead a healthier life. And that is not something that is in a book. That is something that I think is innate. And you just exude it when people are around you. They know that they can trust you, and they know that you're listening to them, and they know that you are going to do everything in their power to help them in their time of need. And that's something that we must do as clinicians. And so that involves asking questions, that involves listening, that involves saying, you know what, I don't even know what that is. Let me get back at you. Let me go look that up, or let me go talk to somebody who knows a little bit more about something than I do. And that's okay. And I think that patients respect that, as opposed to having somebody sitting across from them who is faking it and telling them lies. So I think it's about really treating people with respect. It's about establishing that rapport, all of those things that we've kind of learned in school. But really, that's what it comes down to. There are times when I'm dealing with people that are on drugs I've never even heard of, and I will say, I don't even know what that is. You're gonna have to tell me what that is, and we're gonna work through this together. And they respect that more than me, sitting there like faking the funk and pretending like I know what they're talking about. So it's okay not to know stuff. I must have been going through something when I wrote these slides, because I was reading them this morning, and I was like, vent with a purpose and a goal to change things you can. Yeah, that's true. So, and especially in these COVID times, I know people that are in the profession that are helping folks are tremendously taxed because of COVID. And it's okay to yell. It's okay to, throw a couple things, not a lot of things. And don't throw things at people, but it's okay to vent. It's okay to do that, but do it in such a way that it's constructive so that you can move on from where you're at. And so I put on here, get help twice, I see. So again, I must have been going through something to say that. So that's to say that we need to practice some self-care. This is not something that is going away. This is not anytime soon. We pray that it does, but because it is here, and that includes overdose fatalities, COVID, I don't know, tuberculosis, whatever it is, these things are here, and these are things that we are going to have to work through. And as professionals in this field, when you're working with people, it's incumbent upon you to take care of yourself as well. And get help. And then also let go of your ego and your pride. Again, letting people know that you don't know something is not going to diminish or the amount of respect that they have for you. In fact, it may increase that. If you have a whole bunch of letters behind your name, that's cool, but sometimes you don't know everything. And sometimes we can step outside of that and allow people with lesser letters inform us of things and teach us things. And so we need to kind of respect that and get along. So that being said, I have posted some additional resources in this presentation. The dashboard that I had talked about is something that is actually kind of cool. If you check that out, and you can kind of play around with the numbers and look at what's going on around the state. That Michigan report that I talked about is also listed here on the bottom of this slide. And then there's some viewing that I think is extremely important. So there's an opioid series on PBS that is extremely graphic, but extremely important for people to see. So you kind of know what's actually out there. And then you will also see that some of the grittier side of opioid use, and the fact that we have elderly people navigating these communities and this lifestyle it puts them at greater risk for being victims of violence and also continued victimization with regard to their continued drug use. Opioids from the Inside is something that's close to my heart because I was featured in it along with some of my colleagues and some of the people that some of the patients that I worked with in corrections. And so PBS had suggested doing a documentary on working with people affected by the opioid problem within our community, but in the correctional setting. And so there are some older people in the video as well. And you can see they track some of the people and their life stories. And so I included it here because you'll get to see some of the local landmarks and some of the local scenery. For those of you who are in the Rochester area, from those of you who are not in the area, watch it anyway. It's really good because I'm in it. No, I'm only kidding. And so locally, there is a link here to talk about where you can dispose of your medications, because as we learned earlier, a significant percentage of people have medications in their home that they no longer are in need of. And some of them could potentially be opiates, and some of them could potentially fall into the wrong hands. And so there are safe methods and safe places to dispose of your medications. And then the Monroe County has a special website specifically geared toward opioids and finding out about resources in our community. It's we're going to revamp it, but for the most part, all the information is there. We're just going to tweak it a little bit. And then the Center for Public Safety Initiatives is also, I was a product of that over at R-AHEC, and they have some pretty good research on the local drug scene and the political response to crime and other public safety issues. But they have some pretty good information, and they took a deeper dive into the statistics from the Rochester Police Department. And let me just say one other thing about our local information. All of the local information with regard to deaths and fatal, overdoses, there's a conflicting data in our community. And so like the medical examiner has one number, and then the sheriff's office has another number, and then EMS has another number. Either way, the numbers have gone down, but there's work to be done. So with that being said, please be safe and continue to help one another and help our community heal from all of the things that are ailing our community right now. And so thank you so much for having me here. As I mentioned, my contact information is in this presentation, so feel free to reach out if you need anything. And then for those of you in the local area, please stay tuned for our outreach efforts. Once we get fully staffed and everybody's onboarded, we will be hitting the streets and trying to help our community heal from this scourge of opioids. So thank you very much for having me.
Thank you so much, Dr. Smith. Thank you everyone for joining us today. I am going to go to the Q&A box. So if you do have a question for Dr. Smith, please enter it into the Q&A box. We do have one so far for you. And this is asking, can you comment on the safe and proper disbursement of opiates? For example, preventing it from getting in the wrong person's hands, like a child. And I know you gave the link on the website, but where did that link go?
Yes, so I believe in Rochester, I believe there was an actual disposal box for medications that was at the Gates Police Department. I believe it's still there. So like walking into like Town Hall, into the Gates Police Department, I believe that there was a permanent fixture box where you can dispose of your medications. That link that I provided also has ideas on locking cabinets, on just flushing the medications, but then there's people that say don't flush your medications because of the environment. So I would suggest calling your local police department and asking them of when they're gonna have a drug disposal event. Again, given COVID, I don't know what that's going to look like, but I do know about the one permanent location. And then you can also ask your doctor how to dispose of these meds. Perhaps they have some suggestions. Child-proofing your home, locking your medicine cabinet, keeping the drugs locked away outside of the medicine cabinet could also be a method of protecting your home. And then also having those discussions with your kids about the proper use of prescription medications is something that I would encourage. But keeping it out of the hands of people, would probably be best by locking things up or keeping them away from the medicine cabinet altogether.
Thank you. You get a nice compliment from Bernie Shore. This was excellent, and thank you for your hard work. I know I had a couple questions that came up, but I don't want to hog you, so I'm waiting for more questions to come in. Okay, so Ida put in, I find that it can be a tough balance of reducing narcotic level pain meds in the elderly with chronic pain when often chronic pain. That fails things like Tylenol. Chronic pain can reduce quality of life if elderly have trouble with things like ambulation or the use of hands due to significant pain. I hear this from therapy staff often, that some of my patients cannot progress with therapy limited by pain. So any thoughts on that?
Yeah, it was always, it's kind of like one of those push-pull kinds of things. Like I remember in inpatient chemical dependency, we would say like a person needs mental health treatment. And then the mental health provider would be like, no, they need to stop using drugs. That's why they're depressed. They need to stop doing that. And so it was always like this endogenous question about like which came first and which is primary. I personally think pain is pain and it needs to be treated, right? But it doesn't always need to be treated in the sense of medication. And so coming up with alternative means to relieve pain is crucial. I remember, having just shoulder issues, and I was like, oh my God, I need physical therapy. And then I go for physical therapy, and I did maybe like 2 sessions, and then it coincided with my desire to lose weight. So I go to the gym and I'm swimming, like 3 sessions of swimming, and I'm like, I got range of motion back. So, I think what we need to do as a society is have a deeper dive and deeper discussion about pain and ways to alleviate it that doesn't really necessarily always involve medicine, because that's usually first our go-to, right? I got a toothache. Where's my medicine? I got, a headache. Where's the medicine? So I think talking to providers to come to some sort of agreement over like just treatment. I mean, your goal is to help this person transition from point A to point B. And I'm sure the other clinician is trying to, help people get from point A to point B. And there needs to be some kind of reconciliation between the two instead of holding people hostage. If that helps. Oop, you're on mute.
Yep. One of the things that I thought of when you were speaking was that your perspective changed once you saw the data and how there were opioid overdose deaths across the Monroe County region. So I thought about, okay, so she had wanted to go into the inner city and concentrate on that area, so things changed. So it's a 2-part question. So where are you concentrating, if anywhere, and what are the interventions you're trying? And then when we're discussing older adults and opioids, how are we looking at things that are not medication related, especially in this time of COVID and the pandemic and increased isolation and more depression? How are we reaching this population? Because there's an obvious increase in this problem area with this population. So what are we doing along those lines that are not medication related?
So I'll answer the second question first. What are we doing? I think obviously not enough. I think this is the first time that Monroe County has really made a concerted effort by creating a whole new division and a whole new group of people they're going to specifically target this. And so one of the things that I thought about was actually, physically going to where people congregate, and that's usually, housing developments, senior living, and talking about opioids and educating and even Narcan training folks and talking a little bit more about about the seriousness of our opioid issue that we have in our community, and also, getting those meds out of the cabinet, and, those kinds of things that I kind of talked about. But I don't think that there's been concerted effort in the locations where people kind of live and play. With COVID, there are some limitations, right? And so that's stuff that we're kind of talking during the onboarding process, like how are we going to navigate our community given the restriction of people's time and space. So that's something that we need to continue to work on. And I think we have public health educators here that can also talk about other methods of pain, remedying pain. So yeah, there's all sorts of possibilities. Now that we are here and just kind of in the planning phases, I'm still learning about all of the services that the health department provides. And so hopefully I can, use some of those wonderful and talented public health educators to talk about some of those issues specifically for that population. As to what we're going to do, I still think we need to target those underserved communities. I think there are people within our community that have never ever sought treatment for their drug and alcohol issues, and it's time to have that kind of conversation. I also think that we don't really have a lot of boots on the ground in certain segments of our community, and so I would like our team to be able to provide that kind of service, being boots on the ground, meeting and greeting and talking to people in the community. And we are all from these communities, and so we all have a vested interest in trying to help our community heal. So that's one thing. But I mean, I'm looking at the wall because I have those big, Post-it notes all over the wall. And so since I've been here, as I talk to people and learn more, I'm like, great, I gotta take this one down, and then I gotta like redo it and like come up with a new strategy. But I think, yes, we still are going to target those communities. I think we are also going to partner with other organizations who are also doing outreach efforts. I kind of envisioned a little village walking down the street. And so if you need help getting health insurance, we have somebody here to help you do that. If you need housing, clothing, food, shelter, whatever, we got another person that's going to help you do that. If you need to get into drug and alcohol treatment, we got somebody here for that. You need mental health, we got somebody for you. So I'm just thinking of the ability of our team to work with other teams to kind of partner to help do a lot of good in our community. So it's evolving, but I'm glad it's evolving, because I'd rather be informed and go out and do what is necessary than kind of what I think is what's necessary, and go out, doing the work that the community has said that we need. So that's what we're gonna do.
Thank you. And along similar lines, we have a comment in the chat about what do you think about the role of alternatives to pain, not just modalities like acupuncture, but in particular CBD. So any thoughts on that?
That's anything and everything that is possible to help people heal, I'm for, as long as it's legal. So yeah, I am definitely with that. I think meditation, right, whatever it is, I think we need to have those discussions, because again, I'm the same way. I mean, I got a prick in my back, let me go get some ibuprofen. Like, it's just, it's innocuous. Like, it just happens automatically. And then the moment we think of pain and discomfort, we reach for something external when we could kind of gravitate towards something internal to make a difference. Just a thought.
Yes, no, very good thought. We all need to, I mean, how do you get that information out there to change the mindset that we should reach for something external? How do we start focusing on the mental health condition of our common community, so that we all can think about how can we lift each other up and make each other feel good, rather than just reaching for something else that'll make me feel good for a short amount of time.
I think all of those things are things that have been affected by COVID. I mean, had we not had this, we would have the ability to dream bigger and partner and see each other and be with each other and hug and love one another and just, resume some sense of normalcy, but also educate, inform, and motivate and inspire people to do something different. We had that ability when we didn't have COVID. And then with COVID, we've had to kind of rethink, and then so everything's virtual, but then we have to have people that have access to computers. We also have to have people that are willing participants, and it's a little bit different when you're doing it virtually. Yeah, it's just something that we have to kind of, I think, as a community, come together and make things happen. A lot of things are happening among county leadership and government, in the addition of new people, my new division, and just there's a whole different mindset than I'm familiar with since I've been here, that I think is going to be extremely beneficial for our community, in particular around the issue of substance use and mental health.
That is very encouraging to hear.
Yeah, it's nice to see.
So one other comment in the Q&A says that movement is so important to the improvement of pain. It doesn't seem so since it hurts to move, but we have to get that education out there that there is improvement after the pain with movement. So thank you for pointing out the swimming example.
Yeah. You're welcome. Thank you.
And Christine, did you have anything you wanted to ask or add?
No, wonderful job. Thank you so much.
Well, thank you for having me. I appreciate it. And I love having discussions like this. And anytime you, anybody needs something, me, my team, people here at the health department, we are at folks' disposal to discuss these kinds of deeper issues. So thank you again for having me. I appreciate it.
Thank you, and so glad to have you as a wonderful resource for this community. So thank you again for the talk, and we look forward to having you back in the future for an update.
Oh, thank
Yes.
you. Thanks, everyone. Be safe, everybody.
Yes, have a great weekend, everyone. Thank you.
Thank you, guys.
Bye.
Bye.